or to go to the digital orthodontic. We have now a crisis. The crisis, there are three on the horizon. For example, remember Smile, Direct Lab, or similar companies to try to sell the aligners or the different types of appliances online, even for blanching the teeth, even for the TMG treatment, even appliances for these people who present sleep apnea. All the different companies try to send the appliances to the patient directly. Remember this is the famous from Spencer Johnson, who moved my cheese? What is my attitude? What is my attitude in relationship with the crisis? Now in relationship with the coronavirus, because the coronavirus, the crisis, will change all our future. For this reason, it's very important to adapt our office to the new technologies. Why? Because maybe today you are the best dentist in the world, but tomorrow you will wake up in a world that doesn't not exist. For the reason, it's very important to adapt our clinic to the new demand. For example, who is shopping online? You can see here, when we are talking about shopping, when you are talking, you can see here, okay, the millennials, the shopping in the millennial online is close to 41%. Okay, for this reason, we have to focus in different systems. You have to focus on what makes you different. And for this reason, it's very, very important in the office. In your office, it's very important to focus what makes you different. And for this reason, in my opinion, there are, or in the future, two types of clinics. The clinics center in the caries, this is the old clinic, and the new clinics centered in the smile design. For example, this is a patient with this malocclusion. What is the treatment for this malocclusion? The ideal treatment for this malocclusion, the best treatment for this malocclusion is this: to extract the roots, to clean the teeth, to align the teeth, to correct the protrusion, to close the space, and to open space to put in the upper and in the lower, implants. This is the best treatment, or even the unique treatment. For the reason is very important, because in the future with the digital orthodontic, we will have a lot of information about the patient, about the 3D cephalometric analysis, about even in the Plameca 4D, 4 dimension, we have information about the TMG movement, about the occlusion, about the functional occlusion, about the quality of the bone, the superposition of the intraoral scanner with the CBCT produce a big change in our orthodontic treatment. For the reason, can a GP, the general dentist, without orthodontic knowledge to do a good plan of treatment in this patient is very, very difficult or impossible. For this reason, it's very important, because more than 80% of the GPs, of the general dentists, don't have enough orthodontic knowledge to treat patients. And this is a huge problem, because the main problem is this: most of the patients need big restoration. Normally, this patient presents a big or an evident malocclusion. For this reason, Houston, we have a problem. The dentist has a problem. We have a problem because we need to increase the orthodontic knowledge in the GP not only in the orthodontist. The GP, the general dentist, need a new focus in the orthodontic. For the reason in the conventional on old-fashioned clinic is the caries clinic with the GP in the center of the clinic. In my idea, the new clinic is the Smile Design Clinic. The Smile Design included the treatment of the malocclusion, the treatment of the skeletal malocclusion, the treatment of the muscular problem, the treatment of the sleep apnea problem, the treatment of the oral reading problem, and the Smile Design. In the center of the Smile Design is the orthodontist, and around the orthodontist is the GP, the periodontist. I started many years ago to use Invisalign, to use aligners. Unfortunately, many years ago, Invisalign and other companies didn't work. It was a complete disaster. We are talking about 15 years ago. Nowadays, the aligners, Invisalign and other companies works very, very, very well. It's very important too in the use of the aligners. It's very important to know the clean check, to understand very well the use of the attachment and the use of the ortho stripping. Okay, this is the typical patient with Invisalign, with aligners. This is I need to put a lot of attachment and combine this attachment with a very good organization of the aligners, and at the same time, we need to do a lot of stripping, okay? A lot of stripping. For example, patient like this within a space in the upper and a space in the lower, okay? And we need to close this space. We need to close this space. I put a lot of attachment in the posterior part. These attachments are for the stabilization of the liner, because it's very, very important to understand this, to try to close the bite, in this case an open bite, to close the bite, to retract the lower incisor, to retract the upper incisor, and to close this space, we need two things. The first is the very good stability of the aligner in the posterior part, okay? And the second is the use of the aligner during the life, because this is a patient with a typical osteodental discrepancy positive, and maybe with the tongue is possible to reopen this space, or to put in the lower, if the patient prefer, to put a lingual order. Many years ago, I used the aligners and with the Smile Secret system, is similar to another system. And we use this system only for cases like this, very simple. For example, in this patient, present a lateral incisor with a little bit protrusion, a crowding in the lower incisors. And we use, you can see here, the aligners to correct the lateral incisor and to align the lower incisors. Okay, the patient before and after the treatment. In other cases, the patient come to the office to try to align the teeth, to improve the smile design. And one of the big advantages of the aligners is the expansion. In this case, we use the aligner to produce expansion in the upper arch, expansion in the lower arch, and to move and to align the lower incisors. Okay, you can see here, before and after the treatment, the use of the attachment in this patient, in this case tooth, the lower canine, to produce a expansion with a point of pressure inside, and to use an attachment to produce the rotation of this canine. Another patient with a class 2, division 2. This is a very, very simple treatment and very effective treatment with aligners, because the main objective here is to produce the protrusion of the central incisor, a little bit protrusion of the lateral incisor, increase the first point is increase a little bit the intercanine width to move the upper incisor and to put in the correct place. And you can see here how is the evolution of the patient in the lower canines. Always we put attachment to control the rotation of this tooth. And another patient, the patient wants to put veneers, and we combine to the patient to produce expansion of the upper arch, except in this part of the, because the patient has a bridge here. And we use the expansion in the upper arch, the protrusion of the lateral incisor, and to move forward the lateral incisor, alignment of the lower and the upper incisor, very, very important, stripping, a lot of stripping. Normally, the use of aligners need a lot of stripping, and we use the mechanical ortho stripping. Okay, what is the advantages of this? This is from the Nemotech company, and this is you can compare, start, and the evolution of the treatment, okay, with different aligners. You can check in different colors what is the evolution of the aligners. Remember that one of the advantages of the aligners is the use of with the use of the aligner is with the aligners it's very difficult to find radicular resorption at the end of the treatment. It's more dangerous in this sense, the wires and the brackets. Remember that the orthodontic tooth movement is an inflammatory response to the periodontal tissues, okay, depends of the vascular activity, and for this reason, it's very important the bone resorption and the role of the osteoclast and the osteoblast and the enzymes like rank and different products depends of the bone resorption. Okay, this is the relationship between the use of the aligners and the orthodontic tooth movement, the biomechanical and biological elements who play a very important role, and this is very important. The osteoclast in the use with the intermittent forces in the aligners, diminishing the risks of radicular resorption, of the apical radicular resorption in compare with the conventional brackets and wires. Remember this, when you put an aligner, it's the same, increase the permeability, the vasodilatation of the capillaries, the neutrophils change and produce macrophages and cytokines, and the cytokines play a very important role in the biochemical elements in relationship with the orthodontic tooth movement. For example, if you are using, if you take pills like aspirin or indomethacin, remember that this produces an inhibitory process of the different elements in relationship with the prostaglandin systems. For example, the arachidonic acid. Remember, the cytoskeleton is a very important element in the new concept about the orthodontic tooth movement, and the oxidonitrosus synthesis. Synthesis is very important in response to the pressure of the aligner in relationship with it. For the reason we try to reduce the treatment time is very important in our office, and for the reduce the treatment times is possible to break the biological or the biochemical limits. Unfortunately, the biological limits, even the corticotomies, even the use of different type of appliance to vibrate and to move the teeth, the machines to try to stimulate the orthodontic tooth movement, no enough evidence about the use of these elements or even about the use of laser. We did a research with the chairman of the University of Santiago de Compostela many years ago, and we developed with a digital orthodontic a model of the mandible, even study the different elements with finite elements. We study the relationship between the biomechanics with different brackets and aligners. And now we work with OrthoPlus in research, innovation, design, and development. We analyze all of these elements. This is the printing, okay, the OrthoPlus. This is the printing for the Alinea Dent. And this is my colleagues from Alinea Dent, technician, engineers to work in different parts. We are starting analyze the biomechanical of the with final element methods. This is a mathematical model. We analyze the orthodontic tooth movement and how is the morphometric, the radicular morphometric, how is the behavior of the root when we apply different types of forces in the crown. When we use bite blocks, we analyze this part of different elements. How is the relationship with the periodontal ligament? And here is the same. It's very nice. This is the effect of the aligner, and how is the effect of the aligner in the neighbor teeth. For example, when we try to rotate one incisor, one central incisor, we analyze what is the effect in the lateral incisor and in the other central incisor or the other side. Okay. We design in relationship this type we are analyze this type of attachment. For example, in this patient, we development different attachment because we need to move this lateral incisor forward. We are using this attachment to always to the stabilization according with the third law of Newton. We use this attachment to the stabilization of the aligner and move this lateral incisor in the upper and align the lower incisor in the lower. In the lower incisor, we need to do a lot of stripping. Or this is an aligner in kids. It's the same. We are using in kids a lot of attachment in the four upper incisor to control the space between the molar and the lateral incisor, and to design the special eruption guides with aligners to get to the best position the canine and the premolars. The different designs of attachment, the rotation attachment, a mix. This is a mix attachment to control the second order bands in the canine and the premolar, and at the same time to control the rotation. We use the platform, and this is the platform from Alinea Dent to send the records, the digital records, and after the send to the photos, the intraoral scanner is possible with this type of clean check to design the result of the patient. Another very important topic in our office in relationship with the digital diagnosis is the digital diagnosis and the digital plan of treatment of the obstructive sleep apnea. Obstructive sleep apnea is very, very important nowadays in the kids and even in the adult patients. Okay, I recommend to read this paper. This is a 2039 1 year ago, American Journal of Orthodontic and Odontofacial Orthopedics. And this is an American Association of Orthodontists white paper. And I think it's very, very interesting. It's very strongly recommended that orthodontists be familiar with the signs and symptoms of sleep apnea. Very important for a screen patient. Very important to refer the patient. It's recommended that the orthodontist refer pediatric patient or orthodontic patient with nasal obstruction or aneudectomia and hypertrophy of otorrino. It's very important to understand the training. We published many years ago with my colleagues a paper in 2005 about the evaluation of the intraoral appliance in the treatment of obstructive sleep apnea syndrome. Nowadays, in the research service of orthodontic, of my orthodontic service, we work together with OrthoPlus about the use of this type of appliance. This is, you can see here, an appliance for adult patients. Okay, we use the Ortho Apnea is a platform to design different appliances for adult patient. This is the one model, and this is the new model. This is a new model it's a new generation for intraoral device or dam to move forward the mandible during the night. And this new device is according with the movement of the condyle, with the movement of the mandible. And I think it's very important because digital orthodontic comprehend, including this. This is from Philips, but there is a lot of different companies. This is a system to analyze in my office, in the dental office, what is the risk of the patient to present sleep apnea syndrome, even for the kids and even for the young people or the others. This is very important, the digital design of the appliances, the digital diagnosis of this patient, of this type of patient. This is a patient with a maxillary collapse. What is the problem? The problem is the tongue. When the patient presents a maxillary collapse, the tongue is in a down position and produce oral breathing. Oral breathing, in my opinion, in patients like this with a very long face is a very huge health problem. And it's, for this reason, is dangerous. It's necessary to change the maxillary, to expand the maxillary, to do a rapid maxillary expansion, to change the anatomy or the morphology of the face, to change the position of the tongue, and to change the oral breathing. We use different types of oral breathing, even with mini screws or with mini implants. We published with Professor Juan Cobo from University of Oviedo in February in 1992 in the Journal of Clinical Orthodontic, a very popular study about the use of the different systems to analyze the effect of the rapid maxillary expansion in the palate. For this reason, it's very important to understand the craniofacial growth, the counterpart, and the part. If you produce an expansion of the maxillary, increase the counterpart, and the counterpart is the upper airways. For this reason, it's very important in this patient to use different types of rapid maxillary expansion. In this case, is the La Rosa system. We use the second temporary molars, the screw, a little bit pieces of wires to push the first molars, the rapid maxillary expansion, the spectacular effect of the rapid maxillary expansion if you take a CBCT, or in this case, a conventional cephalometric teleradiography, frontal, and you can see the open the space, open the palate, open the upper airways. The most important is very nice to see the new arch form of the patient, the new development of the maxillary, but the most important is this, the face. You can see how change the face, how change the oral breathing, how change the complete morphology of the face thanks to the rapid maxillary expansion. For the reason in this case, in my opinion, I am medical doctor and dentist. In my opinion, rapid maxillary expansion, the digital expansion of the maxillary is very, very important to understand the result. Another patient with a severe collapse, rapid maxillary expansion, and please, please remember this, the dramatic change of the face of the patient. A patient with a complete different eyes, the complete different mouth, the complete different narinas, and you can see now with a very good seal of lips, change the breathing and change all the face. I use in many cases from Leone Company another type of screws. This is from Professor Lantieri, the Claudio Lantieri, and my friend, and it's a very good. It's the Lantieri screw. We use a night tie piece, and nowadays even eliminate the screw and use only this type of the screw, and it's very nice because it's very comfortable. The patient is not necessary for the patient to turn the screw at home, only to turn the screw in my office every 10 days. And it's normally, we need 20 days is enough to get a very nice, rapid maxillary expansion. Another very important issue is the about the adult patient. The adult patient with night eye. Why it's possible to use with this type of night eye rapid maxillary expansion or with mini screws, and in other cases we use the digital appliance to use during the night and to avoid the use of in many cases to avoid the use of the CPAP. Okay, the appliance is is a device for to move forward the mandible and to maintain the upper airway during the night. Okay, and we have different designs and different types of appliances. This is a very nice research. This is the digital research about the finite element method with the mandibular appliance device or a mandibular advances device. And the idea of this mandibular the appliance is to move forward the mandible according with each patient, and to take the best position of the mandibula to have the nice opening of the upper airways. In other cases, we use the digital TMG splints. Okay, we use splints in the TMG treatment. We divide the patient in maybe the problem in the TMG in patient is the problem is a mechanical patient. It's a mechanical problem only at the level of the TMG or at the level of the dental occlusion. In other cases, the main problem is a muscular and ligament problem. And the third case is a neurological problem. It's in relationship with the adaptation, with the emotion, and is in relationship with the psychological balance. For the reason, it's very important to divide the TMG problem in 3 parts and to analyze the combination of each other. Okay, for example, patients who present problem at the level of the teeth, or problem at the level of the TMG, or problem at the level of the muscle and the ligaments, at the level of the psychological or psychological balance. And in my opinion, the bruxism during the night is a huge problem. Why? Because the bruxism produces compress of the TMG, the same that the malocclusion with deep bite and collapse of the posterior molars produce hypoxia. The hypoxia altered the chondrocytes function, altered the ground substance, and the loss of the chronotrine and glucosamine surface. The main problem is the loss of the collapse, the loss of the joint space, and the loss of the joint space for a biochemical and biomechanic patho produce a second change. The second change included the articular deformity, subchondral sclerosis, subchondral cyst, synovial hypertrophy, and subluxation. For the reason you can see in the CBCT of the TMG, a lot of problems with the TMG. You can see the loss of the structural integrity. In many cases, you can see the glasses of right Charles in the anterior part of the condyle. This is the displacement, permanent deformation and permanent luxation of without reduction of the meniscus. And this is a very bad sign of the TMG. And I like very much in this patient to analyze very simple in the first appointment. In the first appointment, very simple, the TMG. For example, the cotton test. The cotton test is very good. You put a cotton test between the upper and the lower molars. The patient bite, and when you put the cotton test, and the problem is a muscular problem, is very painful for the patient, but diminishing the pain of the patient when the problem is in a compress of the condyle in the retrodiscal area. We can use the digital records, a lot of typical, I like very much a very simple records like the Gothic arch. It's very cheap, is very clear. I like very much. Like this patient, we present after an orthodontic treatment. I treated this patient many years ago, and now after the TMG, after the treatment, the patient come to my office with a problem at the level of this molar and present cracking, okay, and pain in the area of the massetero, internus massetero and pterygoidea. We use the different type of movement for the Gothic arch, check the relationship or the contact between the lingual cuspid of the upper molars with the lingual cuspid of the lower molars. And you can see here a very nice Gothic arch. This nice Gothic arch indicates to us a very good function in the horizontal plane of the right and the left condyle without dental prematurity. For the reason I like very much this type of very simple. What is the ideal treatment in our office about the TMG? For example, this is a patient with a class, with a deep bite, TMG problem, present retrodiscal area, pain in the retrodiscal area, and we divide the TMG patient in the first appointment, in the first minute, we divide in patient with a pure TMG problem, patient with a malocclusion in relationship with the TMG problem, a central nervous system problem or psychological problem or psychological imbalance. What is the main problem of this patient? Very simple. The main problem of this patient is the retrusion of the upper incisor produce a compression of the retrodiscal area. What is the best treatment? The best treatment maybe is to put in a splint, but we have a different approach to use splint in all patients, because this is a problem. You have a very good diagnosis, but all the patient use a splint. Not in this case. The idea is very simple. The first step is to move forward the upper incisor. The first step after the use of the pills, the pills or something, the emergency treatment. But I don't like to use, in this case, the splint. The first step before the splint is to use a removal plate, very simple removal plate. This is not digital, but now it's possible to do this digital. What is the secret of this removal chip appliance? Only one question. A very good design, and please use good materials. Don't use the horrible stainless steel from the technicians. Use LG-Loy. Use good wires. Use stainless steel of a very good wire. Okay, I put the removal appliance. Even here, I put a little of composite. Here and here, put a composite to retract the lateral incisor. After the use of this, in the lower, put brackets, because for the patient it's not a problem to put only in the lower, not the patient hate to use brackets in the upper. The next step is to use a white wire with these tubes of the static tubes. I put the composite of this more or less the same color, and finishing with an aligner. And I think it's a very, very interesting, because this is a very simple approach, using at the end few number of aligners, and the patient is very, very happy with an invisible treatment in the upper arch. But to avoid the use of a lot of aligners, I prefer to use a removal plate at the start of the treatment. In many cases, I use this. For example, in patient to do expansion, I prefer to use, in many cases, a removal plate to do expansion at the start of the treatment, and use after the use of this removal appliance, is possible to use an aligner. Okay, for the reason we have, we use different types of systems, different types of software about the photo, about the CBCT, the combination between the CBCT and the intraoral scanner is very nice. This is our technique. This is the synergy bracket we combined with the CBCT. This is a very, very old photo, maybe, I don't know, 7 or 8 years ago. Yes, 8 years ago, we used it with Miguel Angel from Nemotech. Use this type of cell. For example, it's very useful for this to take a decision about the extraction of the expansion. For example, in patient with loss of the alveolar bone, different types. Okay, for orthodontic surgery, okay, for setup and mock-up. For setup and mock-up, and we can use a lot of systems like this. Okay, different systems to show you the use of the intraoral scanner. The use of the intraoral scanner. the design of your smile. Different, we have a bank of teeth with different types. Very important to analyze the proportions between the central and the lateral incisors. Okay, to get you can select different software in the market about this. And it's very useful in orthodontic, but remember, without orthodontic is a problem because in most of the cases, you need orthodontic treatment before to use veneers or crowns or aesthetic crowns or different designs, okay? It's possible to do in the 2 dimensions in the laptop, or it's possible to do with 3D in the real position of the patient. The different programs. This is, I think, is I don't know. Maybe this is from Plameca. Is to take a decision about how to move the teeth. It's possible to move the teeth for the mock-up first, to do the setup, and to use this mock-up to design to show to the patient the result of the treatment, to design the aligners, to put the indirect bonding of the patient, to put brackets and wires. Okay, different types of this. There is a different types of programs. And this is a question to take the program and to work with it. This is another software. This is from 3Shape. 3Shape is a very, very good brand to take the models, to the connection between the scanner and the model, to do the veneers or prostheses, to put in implants in the plan of the treatment, to put brackets. We have the brackets from our technique. Okay, and we have the synergy. The digital synergy with the synergy, the wires, and the use of the microimplants. In my technique, the most important characteristics is this. This is a conventional bracket. In the conventional bracket presents a lot of biomechanical problems. The main biomechanical problem is not possible with the conventional brackets, even with the self-ligating bracket, to put thick wires at the end at the start of the treatment. We need to put 2, 3, or more round wires before to put 90 by 25 if you are using, for example, 22 slot. And this is the advantages of the synergy. Synergy is a very well-known and very old bracket. It was designed more than 15 years ago, but it's a spectacular bracket in my opinion, because works very well at the start of the treatment. In the strike wire low friction, in our technique, the second arch wire in our office is always 90 by 25. What is the advantages of the synergy? Is this very simple. it's possible to select the friction. It's possible to select the orthodontic tooth movement, tooth by tooth, only changing the ligature. It's very cheap, very easy. If you put ligatures in the center, in the figure of, in the center only, the friction, according with the research, is close to 0. It's the same like the synergy cube. And if you ligate in the figure of AX or in figure of 8, increase a lot the friction and diminishing the sliding. I think for this reason, it's a orthodontic differential movement. For example, in this case, we need that the 21 tooth move mesial without movement of the other incisor. Put the first in this situation and now in this situation. What is the advantages of the diamond bracket is this. The diamond bracket or the self-ligating brackets or the Carriere bracket, self-ligating brackets present the advantages at the start of the treatment, the big advantages of the sliding, a very good sliding. Is the synergy, and the synergy is the same. We ligate in the center, and when we ligate in the center, we get a very, very quickly movement with very important and different with self-ligating bracket. Very important with thick rectangular arch wires. Now it's time to finish in the treatment. What is the problem of the self-ligating brackets? The main problem of the self-ligating brackets when you are finishing the case is the lack of friction. In the synergy, you put now ligature in a figure of conventional or in a figure of 8 to control the torque. Now we are working in this structural low friction indirect bonding. We're using the indirect bonding for the attachment of the synergy bracket. You can see here in a patient. And we are working in the automatic selection of arch wires according with the deformation of the wire, according with the irregularity index of the patient, and according with the alloys characteristics, according with the thermal or the biomechanical behavior of each wire. For the reason here, for example, is when we start the treatment, with the strike wire low friction, we analyze the angle of the deflection, the relationship between the angle of the deflection, between the irregularity index of the patient, and according with the irregularity index of the patient, and according with the crown. For this reason, it's very important to understand what is the repercussion of the digital system in all these patients. This is the big advantages to start the treatment with, in many cases, with 90 by 25 night-type wire, thermal wires. Cases like this with a class 3 malocclusion, start with a removal appliance. I like very, very much the removal appliance. The removal appliance and the digital removal appliance is cheap, is very spectacular because the treatment in many cases like this is a TMA wire. This is a not very bad stainless steel. This is TME wire, and we are using this removal appliance to retract the lower incisors and to produce the protrusion of the upper incisor. Now it's time to use an utility, protrusion utility arch wire, and now we are put the indirect bonding and it's the braided stainless steel 90 by 25 in the upper and in the lower, short and heavy elastics, and finish the treatment. Finish the treatment. Another patient, another class 3, edge to edge with a hypoplasia of the maxillary. Okay, class 3, protrusion of the upper incisor and the lower incisor, The first step, edge to edge, open bite, class 3, hypoplasia of the maxillary. What is the treatment sequence? The first step, the same, digital orthodontic appliance, okay? We produce a removal appliance to produce the protrusion of the upper incisor, retrusion of the lower incisor. Now, I like very, very much the concept of rickets about the utility arch. Okay, I show you later when we are going to talk about the incisal eruption proprioception, guys, is the same philosophy. The only instead to use brackets and wires and bands or utility wires, we are using aligners, but it's the same philosophy by rickets. We are using now a facial mask. In this case, the facial mask is for the dental movement, not for the orthopedic movement. It's for the dental movement. Okay, and now it's time to finish the first phase of the treatment. It's time to the break time, and unfortunately, the patient after the break time present a canine included in the palate. Okay, we use now the gum metal. It's a spectacular wire for the equilibrium between the elasticity, okay, and the stiffness, and also because the gum metal is a very simple to bend. It's very simple to bend. In this case, we bend the gum metal to control the torque of the 23 of the canine. You can see here how we can control the torque to move the root of the canine to the vestibular. We are using now intermaxillary elastic, heavy intermaxillary elastic in triangular class 1 and in class 3. Okay, stripping in the lower and stripping and finish. You can see the control of the torque is very difficult, for example, with aligners to control the torque. I prefer to use, in this case, the classical wires and brackets. Finish the treatment, the sequence of the treatment with the first phase of the treatment, the break time and the second part of the treatment, the follow-up of the patient years after the treatment, okay? And the follow-up without periodontal problems in this patient. In other cases, we use a trick, and the trick is use this wire, or even it's possible to use white wire, and use the white wire to combine with small tubes, static tubes, for example, in this case, to align the upper incisor, to align a little bit the lower incisor, okay, and to combine with a periodontal treatment and another case. Okay, another question, very important, the neuromarketing in the design of the smile. What is neuromarketing? Neuromarketing is in relationship with the new researches about the technologies to see the different process of the brain, like magnetic resonance imaging, the functional magnetic resonance imaging, to study the brain's response to the marketing stimulus. We have 3 parts of the brain, the reptilian, the limbic or emotional, and the cortex, the rational cortex. The rational cortex was described for Santiago Ramón Cajal, a Spanish doctor, Spanish research, Nobel Prize in 1996. We have the conscious brain, the unconscious brain, and the subconscious brain. This is the hard driver, the feelings, the emotions, the behaviors, the habits, the permanent memory. This subconscious is very, 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 very important. It's very powerful. It's very powerful. And you can see that 90% of the time, we are working with our subconscious and fast system. What is fast and slow is, according with Daniel Kahneman, is a Nobel Prize, is a psychology, but this is Nobel Prize is very funny in economy because it's the take of decisions in economy. In many cases, is very crazy. And according with Daniel Kahneman, there are two systems. The system one is fast, instinctive, and emotional. And the system two, that is slower, more deliberative, and more logical. Unfortunately, we are working 90% of the time with the system one. And the patient in our office is thinking with the system one. And the patient and the people, when we are going to shopping, is with the system one. The system two is, now we have a lot of system two with the coronavirus inside of the house. The system one is fast, is full of prejudice, false perception, stereotypes, and a halo effect. And it's very easy to wrangle. For this reason, this is the system one and the system two. Remember this, the system one is very important for the patient, to take a decision, the patient, in our office. Our brain is lazy, emotional, more rational. 90% of its operation is automatic. It likes the emotional shopping, and the emotional shopping produces to our brain pleasure. And the neuromarketing study what is the back door of our brain. For the reason when a patient comes to the office for an orthodontic treatment and say, oh, I divorced, and now I like to have a new spectacular smile. It's completely different. This patient than the patient who comes to the office and said, oh, I have a problem with my tooth. Please treat my tooth as soon as possible and more and cheap. Okay, this is completely different. The first patient is an emotional patient. The second patient is a rational patient. And it's very important in our office because the emotional patient, the patient who said, I would like to have a new smile with veneers, with orthodontic treatment, is completely different to the, I have only a problem here in my tooth. Why is important? Because we have in our office only 20% of the emotional patient. But the 20% of the emotional patient produce the income of our office, the 80% of the income of our office. The question is not to increase the budget of the patients. The question is to select the patient. Why? Because the emotional patient wants the treatment for emotional reasons, to increase the happiness. The emotional patient do not buy what they need, buy what they want. Excuse me for that. For example, if I am going to sell a periodontal treatment, I need to talk with the cortex of the patient, with the rational part of the patient. Why? Because the rational part of the patient is in relationship with the losing teeth, to losing a guarantee, or to losing money. For the reason, you use a small piece in the casino. Okay, for this reason, when we are talking about periodontal treatment, we need to talk to the cortex of the patient. But when we need to sell aesthetic treatment, veneers, orthodontic treatment, we need to talk to the limbic system or emotional part of the patient, Why? Because the static treatment is in relation with emotion, with the happiness, with the feeling, and very important, with the self-esteem of the patient. And is in relationship with the halo effect. It's a type of immediate judgment discrepancy or a cognitive bias, where a person making an initial assessment or another people, today is very frequently because we have a lot of contacts every day, and not today, in the normal life, we'll assume ambiguous information based upon concrete information. For example, when in the patient smile and the person is thinking in youth, social status, smartness, loveliness, wit, sexual success, and different properties. For the reason, this is very important. This concept about the association is very important. For this reason, in the business, try to the association between the racket and Rafa Nadal, or the boots and Ronaldo, or the boots on the ball, the football ball, with Messi. What is our feeling about these photos? The feeling of the people is not only about the smile, the nice smile. The feeling of the people is thinking in these photos about what? About happiness, lovely, successful, everything that the people want to improve in her lives. For the reason, you are thinking in lose weight, you hate this type of announcement. Why? Why do you like this? This is an absurd, because it's very young girls try to lose weight. It's absurd, but the question is about the limbic system, and the question is about the desire. Desire is the most important, because when a patient comes to the office for a dinner to put whitening or to use a blanching, this is an emotional patient. Do not buy what they need, buy what they want. And 20% emotional patients profit in our office. 20% of our emotional patients in our office reduce 80% of the profit. How to transform the emotional patients, rational patient in emotional patient? Wash the brain of your patients. You must to transform the rational patient into emotional ones. For example, this is a patient. This is a real patient who comes to my clinic office many years ago and asks for a dental treatment. Okay, dental treatment. I suggest orthodontic treatment, vestibular. No, hate. I suggest lingual treatment, orthodontic lingual treatment. No, because the lingual treatment maybe is very painful for my tongue. I recommend veneers. Oh no, because you are bleeding and feeling my teeth. Blanching. Oh no, because it's very painful. Maybe in the after the blanching is very painful when I try to drink cold water. No, patient. What is this type of patient is terrible. What is my problem? My problem is I am talking with the cortical brain of this patient. I need to talk with the emotional, with the limbic system of the patient. The first step is to decide a smile design. The smile design is the anterior boundary of the smile, upper incisor position, skeletal problem, dental problem. Okay. The first step, cephalometric analysis, please. To organize a very good smile design, we need a cephalometric analysis to analyze the position of the upper incisor and the future of the anterior limit of the smile in relation with the face of the patient, in relation with the nasolabial angle of the patient. For the reason that the first step is to analyze the position of the incisor. The nasolabial angle of the patient is very important, the nasolabial angle of the patient, because it's in relationship with the skeletal position of the maxillary and with the inclination of the upper incisor. For the reason it's very important the incisal guide in relation with the TMG in the future to avoid problems with the TMG, and at the same time with a nice smile. It's very important to analyze the lower nasolabial angle, the position of the overjet and overbite, the position of the upper incisor. Very important, in my opinion, this measurement. The inclination of the upper incisor in relationship with the true horizontal or the Frankfurt line in relation with the anterior face line or the vertical line, the interincisal angle, and you can complete this very simple measurement with different types of measurement like this. For the reason, we analyze the point of contacts, the point 50% between the central incisors, 40% between the central lateral incisor, 30% between the lateral and canine, the Bolton discrepancy, the position of the first molar, the incisal guide, the inclination of the second order bands of the lateral incisor, especially the lateral incisor, the torque, the third order bands, the curve of Monson and Wilson, the curve of spin, and the width of the maxillary, 45 in females and 47 in males between the central fossa of the first upper molars. The relationship of the first upper molars, the role of the rotation of the first upper molar, very, very important. What is the Andrews keys? The Andrews keys is the start with the first upper molar, the position of the relationship with the occlusion, the relationship, this point, very important for the dynamic occlusion between the marginal ends of the upper molar and the second lower molar, and the key of the second premolar. Is very important to finish the treatment with the second premolar in a very, very good contact with the lower first molar, like in elephant. Remember, this is the guarantee. This is the guarantee with this key, the guarantee of the proper position of the first upper molar at the end of the treatment. Okay, the inclination, the difference point, the class 1, the correct overjet and overbite, the correct interincisal angle. In the posterior part, very important, the torque, the negative torque. Negative torque. If you have produced expansion in the future with appliances in this patient, and you try to increase the width of the smile of the patient needs wide. Forget to use thick veneers or thick crowns in this. You need expansion, dental expansion, even is
Dr. David, sorry, Dr. Yeah? David. We have 5 minutes left.
Okay.
Thank you.
Okay. And in this case, one moment. In this case, we have different procedures. We have to analyze the side of the teeth. Okay, you have to analyze the side of the teeth. And now this is the model. And now this is the model. We have this part for the mock-up, for the digital mock-up. Put the mock-up in the patient. In the second appointment, I put a easel, something like to put here the composite. Put the mock-up. It's very, very quickly to remove the mock-up. Put the
bond,
the composite, and you can see the patient in the second appointment. You can see the patient in the second appointment, and please check the eyes of the patient. Check the complete different concept now of the patient about the treatment. For this reason, what is the successful of this case is to work in the limbic system of the patient, thanks to the mock-up. And now it's time to finish, to convince to the patient to do combine the orthodontic and the prosthetic treatment. I need this treatment set and now the patient. And could you give me a credit? Because now the patient changed completely the mentality. This is another patient. Don't talk about teeth, talk about happiness. This is the key of your office. The same, another patient with this problem, the patient don't like to do beginners. Okay, I do this design of smile. Even the design of the smile is not very nice, you can see. Even is not very nice. I remove the effects of composite, is not very nice, but this is very important. The patient said, "Oh, David, I love my new smile. I want this." Yes, but you don't like to feeling your teeth for the pin. Oh, no, it's the same. I like this. Change the mentality of the patient. Don't talk about teeth, talk about the happiness. For the reason the same, another patient, this is the digital mock-up. The digital mock-up, we design the smile. You can see the design of the smile of the patient. And this is the result. This is a treatment with Maite Trujillo and Nani from Spain and Italy. We treated this patient in Madrid, in Smile Life. And this is very, very, very important to change the mentality of our patient. Don't talk about the teeth, talk about happiness. If you have another problem is this is the emotional patient, hate the braces, and I have now cases, but I don't have time enough. I have cases with the use of aligners and combined aligners with another appliances. If you like, is finish, and if you want to do questions, okay?
Okay, welcome everyone again. Thank you, Dr. David, for this valuable lecture tonight. My dear colleagues, anyone who would like to ask a question, he can go to the Q&A and write down his question. He can type it. Please go ahead, colleagues. زملائي الكرام، أي حدا بحب يسأل بقدر يروح على سكشن في Q&A ويكتب سؤاله. أهلا وسهلا بالجميع. No open questions till now. We are waiting.
Okay.
دكتور شادي، في أي أسئلة؟
Thank you, Dr. David, for this valuable presentation. We're waiting. Maybe somebody is typing a question, أو إذا في أي حدا من الزملاء بحب يطرح السؤال in person, please you can raise your hand through the blue button ونقدر نعملكم unmute to ask the question in person إذا حدا مش حابب يكتب. إذا حدا عنده أي سؤال على الموضوع اللي تحدث فيه الدكتور.
دكتور عدلي. دكتور عدلي عنده سؤال.
Yes, please. Thank you, Dr. David, for your nice presentation. Actually, I have two questions. The first question about the gunmetal wires. What distinguishes these wires and what is the advantage over the TMA wires? This is first question. Second question about don't tell the patient about the teeth, but about happiness. Do you think that all the time this is ethical? We can do the right treatment for the patient, or just we will shift to another treatment just to make the patient happy, although this is not the ideal treatment?
I think it's the first question is the gunmetal is like something like TMA or beta-3 titanium. The advantages is that it's more easy to bend. It's very easy to bend. What is the big advantages? It's possible with the same alloy, different sizes, to use only gunmetal, except maybe in patients that need a lot of control of the torque, that you need to use stainless steel. But I have in my new technique, in the strike wire low friction with gunmetal, we use gunmetal only for all the treatment. To align, use gunmetal. To leveling, use gunmetal. To closing a space, use gunmetal, and for finishing, use gunmetal. This is the first question. The second question is about the happiness of the patient. In many cases, the patient come to my office, even in my office, and put 4-6 implants, okay? But at the end of the treatment, the patient present the same problem in the incisor, without aligner, for the reason I think that in many patients, the patient love, for the patient, the best is to have a very nice smile. This is in my opinion, except the patient with problems to bite or to eat. But normally to have a very nice smile is the main objective of the patient. And for the reason it's very important to combine the orthodontic diagnosis, the dental diagnosis, for example, a patient with who lose different teeth, and who lose different teeth, and to try always to get to the patient a good smile. This is my opinion.
Thank you. Thank you, Dr. David. I think we have another question. Dr. Muayyad, he says, can you please talk more about gunmetal wires material? So if you'd like to answer him live, please.
About gunmetal, yes.
Gunmetal wires, yes.
One moment, because the question is, I don't like to because one moment.
Sure.
Moment. One moment. Okay, okay, one moment, I have this.
Yes, take your time, no problem.
Okay.
If you'd like to share the screen again for the presentation, there's no problem.
Yes, one moment, please. Okay, I need one moment.
Take your time.
Yes, to take, it's okay. Where is the green? I don't have.
In the lower
right side.
In the lower, well, in the middle. Share screen. If you want to share the screen again.
No, one moment. I don't. Okay.
Yes, just choose the keynote and yes.
Okay. The question is this. This is more or less about this. This is the evolution of the wires. Stainless steel, 19-all, the 19-all austenitic 19-all or super elastic wires. And today the new wire is the gunmetal. Okay, the gunmetal present a lot of advantages of in relation with the force, with the copper. And what is the dream of Angle? In 1997, Angle said that maybe in the future it's possible to do the orthodontic treatment only with one arch wire. And it's possible to do all the treatment with one wire, with one alloy, yes, with gunmetal. What is the advantages of the gunmetal? Is very flexible. The relationship between flexibility and strength and rigidity is very good. Another big advantages of this wire is very easy to bend into the mouth. And this is a big advantage. It's possible to use thick, rectangular gunmetal wire even at the start of the treatment. For example, when 90% of the teeth is in a good alignment and only the problem is one tooth, in this case, the canine, it's possible to use this wire and even to use this wire, they present different types of materials. And what is the, one moment. And for example, it's typical for this case. The patient present an open bite. I use a curve of SP in the upper, a curve of SP in the lower, a very short, heavy elastics in anterior, and with this design of curve of SP in gunmetal is enough to produce intrusion of the posterior teeth, the premolars and the molars, without extractions. Or this patient with a severe problem, the open bite, when I check the patient, in central relationship, you can see in the chair of the office, you can see the contact only at the level of the second molars. Okay, in this patient, we use the gunmetal. I use these T-loops from gunmetal, made of gunmetal, and combine the anterior elastic and posterior elastic to engage the occlusion. What is the advantages is this? It's very easy to bend into the mouth. It's very easy to adjust the occlusion of the incisor and the posterior occlusion, and this is the big advantages to this, to treat this patient with a very severe deep bite. Okay, this is one typical case to treat with gunmetal, cases with difficult cases with open bite and with a differential leveling. Okay. More questions.
Question 2 is برضو, it's also from Dr. Mike Kain. Are memory-shaped thermoplastic aligners going to be introduced soon to the market?
Excuse me, into the market? What the
Are memory-shaped thermoplastic aligners going to be introduced soon?
I don't know, because in the last year, we are talking before the coronavirus. Okay, before the coronavirus, there are a lot of new the new products and new plastics and new polymers to launch into the market. For example, the idea is to do the aligners without the resin model. And the second is to use this type of memory shape polymers. The polymers with a memory of, with a shape, with memory, shape memory. And this is a new concept. For example, if you are using an aligner, Invisalign aligner, or is like a plastic similar to the bottle, to a plastic bottle. The idea is completely different. You put the aligner, and the aligner move the teeth, and maybe you need to use few aligners to correct a malocclusion.
Okay, we have a question from Dr. Abdullah. Could you please talk more about the removable appliance that you used for the treatment of class 3 patient, stage 1, asking about the design and wearing protocol and age of patient?
Okay, one moment. One moment. This question is very, very interesting. Is because I don't like to talk a lot of this, but the concept is the low cost appliances is very, very important. What is low cost appliances? Is aesthetic appliances low cost? Okay, for example, one moment.
Low cost, how much do you mean you will charge the
low cost? Low cost, yeah, low cost is low cost. For example,
in Italy, maybe low cost, but in Jordan,
yeah. No, low cost. I am going to talk about this. One moment. I don't know where is. One moment. Okay. I show you cases. For example, imagine this. This is one moment. This is a patient with the main problem of this patient is maybe the patient presenting ankylosis of this tooth. Okay, maybe, I don't know. And it's very difficult to take a decision about to use a lot of aligners or even to put brackets without, if the patient presents this problem. What is the treatment in my office in this case? In this case, the treatment of my office, because I have a doubt about the evolution of this tooth, is possible is possible that the tooth presents an ankylosis and it's not possible to move. For the reason, my first treatment is with a simple removal appliance. We use a removal appliance with a screw, acrylic, a conventional screw. The price of this screw, we are talking about the $5-6 United States dollars only, $7. The wires, and now we are cut the vestibular arch and put a piece of composite. With a piece of composite and elastic change, this is an elastic change, in this case it's from Rocky Mountain. With this elastic change and a piece of composite is enough to correct the incisor. At the same time, the removal appliance works very well in adult patients. It's not true that the removal appliance works very well in kids. It's not true because the kids don't use the removal appliance. The removal appliance works very well in adult patients. In this case, we use removal appliance and correct the main problem of the patient with this incisor. Now the patient said me, oh no, I prefer to get a very nice occlusion. And okay, in this moment, start with the second part of the treatment. In the second part of the treatment, we are using aligners, okay? Aligners to get a good occlusion. For example, in this patient, we use the aligners to align the lower part. Okay. Okay, one moment. Another.
The slide. We didn't see the slide, Dr. David, that you were talking about.
Did you?
The slide was not shown on the screen that you were talking about.
Okay. One moment. And it's okay. Now it's okay. No.
No.
No. What is the problem?
No, actually now we see it. I think you were not sharing that particular window. We can see.
Okay. It's okay. It's okay. It's okay.
Yes, we see it now. Yes.
Okay. For example, another patient is this patient. This patient, excuse me. This patient come to my office. Excuse me. With an open bite. Okay, this patient come to my office with an open bite. It's an adult patient. It's possible to put a liner from the start? Yes, but in this case, we use a removal appliance, a simple removal appliance like before. You see the before is with a screw, a very simple appliance with elastic change, composite here to produce the extrusion of the teeth, and you can see with a removal appliance, it's possible to get to this situation. And now it's time to put aligners, okay? With the idea of the removal appliance in my office is diminishing the time with aligners. Why? Because aligners is more expensive and take a lot of time in relationship with the removal appliance. This patient, for the patient, it's not a problem to put brackets in the lower, but the patient hates to use brackets in the upper. And we have a problem here. Instead to using a liner, I use a conventional removal appliance in adult patients that works very well. A very simple screw. This screw is $6, $7, $8 American dollars only. The acrylic, this is from Orthoflex for our lab. Okay, expansion. And you can see the result of the treatment using only in the upper arch a removal appliances. Another patient come to my office and said, I would like Invisalign. Okay, do you like Invisalign? Yes, I like Invisalign. Okay, Invisalign is in my office about $4,000 or $3,000 American dollars. Okay, do you like? Yes. Okay, but I prefer to use something more cheaper for you and put a removal appliance, 90 United States dollars only with a removal appliance, with a screw, put in the lower, a new design. I like very much the type of design. We design my own appliances. You put a redesign with a screw, with an alloy wires and a piece of stainless steel wires to produce the retention at the level of the molars. Now we put this. I like very much this. What is this? This is a conventional screw with a removal. It's like the philosophy is similar to the aligner, but using screws. 75 euros, about 90 United States dollars. And with a very, very, very simple appliances and invisible appliances, and the patient using only these appliances at home and during the night, it's possible to get not perfect result, but a very, very, very good result. If you like a very increase the results, it's possible to use aligners, okay? But I think it's very different, the concept. And I talking about the low cost appliances. For example, this is a patient who wants aesthetic brackets, but what is the first step? The first step is to use this very simple removal appliance. Put a piece of composite here, an elastic, a very simple screw, a screw in a fan shape, wires to produce the protrusion of the incisor. And this is the situation of the patient before to use aligners or before to finishing with wire. Another patient, class 2, division 2, okay, the patient present an asymmetrical mandible due a TMG problem in the childhood. Why is the treatment? The main problem is the TMG, and the second problem is the sleep apnea for a retrognatic mandible. The first treatment, very simple, removal appliances. We are talking about the 80, 90 United States dollars only in our lab. The protrusion of the incisor, with these screws produce a little bit expansion, and now you can see the free movement, the spontaneous free movement of the mandible forward, spontaneous, and now we bend the wire, you can see, bend this wire, put an elastic, conventional elastic, put composite here, and with this and this, produce the alignment of the incisor, the unlock of the mandible, and a little bit the intrusion of the incisor. And finishing this case with aligners, okay? And I think it's a good example to the use of removal appliances in this type of patient. I recommend to the all orthodontic societies because the old orthodontic society is aligners, aligners, and aligners. Please don't forget the use of removal appliances, especially in adult patients, to treat small problems in orthodontic. Okay.
Okay, we have a question from Dr. Sharif. One of the problems regarding aligners is correcting rotations. Is this problem have been fixed by Align Dent?
Yeah, no. The problem of okay. I think it's very important to understand this. Aligners is for the etymological name. Aligners, it's for align the teeth. The rotation of the canines, especially the rotation of the lower canine, is very, very difficult with aligners. For this reason, I recommend, please forget 3 years of treatment with aligners. To avoid very long treatment with aligners or very unsuccessful treatment with aligners, my recommendation is to treat the patient with different, with a combination of treatment. For example, when I have in a patient a lot of crowding, my first step is to put lingual brackets, and second, start with the aligners. It's not, I think that in many cases, the patient with a problem in the central incisor, when the central incisor is in this position, is better to put 4 brackets in the lingual, even brackets from the lower incisor, align the teeth, and second, to use the aligner. For example, I have, I don't, I don't have here cases, but
you put the same lower anterior brackets lingually?
Yeah. For example, yes, I have this. For example, this is the typical patient in my office who are coming with demand Invisalign or demand aligners, okay? And I said, okay, no problem. This is not very difficult, but to finish this, to correct this divide, to rotation the premolar, maybe you can choose between to use aligners only or to combine. Okay, the patient is, what is my first step? Is to use a removal appliance with a screw and with this. This appliance work very well. I put these white buttons in the canine, okay? What is the objective of these white buttons is this. I put composite and only with a very cheap appliance, with a very cheap appliance, I correct the deep bite, produce the expansion of the teeth, and now I put lingual, is it the vestibular lower incisor brackets. This is the lower incisor brackets. I put in lingual, and my objective is only to align the incisor. Forget the torque, forget the three-dimensional control of the torque, only to align the teeth. In this case, remove the brackets, and you can see and finish the case. And this is it's not very exactly the midline, but it's okay. This is my philosophy of treatment. It's very important, the low cost in orthodontic, because the low cost in orthodontic, and now in the future with the coronavirus, the low cost treatment is very important. And the low cost depends on the quality of the orthodontist. Okay. More questions.
Okay, the next question. The best orthodontic software for aligners?
I don't know. There is a lot. For example, 3Shape is good. There is a lot of maybe the Invisalign is a very good software. But to make the aligners, maybe 3Shape is very good. Plameca is very good. Different softwares.
Okay, another question. How do you talk to patients that refuse braces?
How to talk to?
How do you talk to patients that refuse to put braces? How do you change their mind?
Okay, depends. Depends. For example, when a patient come to my office and said, "I hate braces." Okay, the patient come to my office and said, "I would like Invisalign," and I evaluate what is the malocclusion and what is the effectiveness of the aligner. When the patient presents a very huge crowding, and the patient won't only use aligner, I explain to the patient the limits of the use of the aligners, the limits, and the time of the treatment. Because, for example, imagine a patient with a severe crowding in the upper incisor. Put brackets in the lingual, and maybe in 2 months is okay. And now start with the aligners. In other cases, when the patient presents, for example, TMG problems or it's a very difficult treatment, I explain to the patient that my best control nowadays is with brackets and wires. And this is a medical, I think it's very different, a medical treatment than the aesthetic treatment. When the patient presents a malocclusion and the malocclusion produces dysfunction, we try to put aligners. But in this case, I prefer to select my best appliance to treat this patient. No, I don't. One moment. Mark, I don't see air two. Okay?
Okay.
Sorry.
Okay, perfect.
Okay. The question, is the expansion with clear aligners, is it tipping or is it real expansion?
No, with aligners in general, depends of the case. Normally, with the aligners, it's possible to move more, control the torque better with the removal appliances. Okay, with the aligners, it's possible to control the torque of the teeth. Okay, with the torque elements. For example, one moment. For example, one moment. We use for example, in the upper incisor in the class 2, division 2, is possible to control the torque with a control of the rotation, and it's possible even to distalize. For the torque, I would like to use in aligners. In aligners, it's possible to use a couple of 1 point of pressure and another point here to produce the torque. The attachment for is possible, depends of the use of the attachment to control the control of the torque of the control of the torque of the teeth. Okay, for example, this part here is for the control of the torque of the incisors and to move backward the root.
There is no screen showing.
Okay. Yes.
The screen was not showing.
It's showing. I see it.
You see it?
Yes.
Okay, let's go for the last question then for today. Thank you, Dr. David, for the nice presentation and excellent documentation from your experience with aligns. What do you use as a quick method to close mild residual anterior spaces and mild midline corrections?
Okay, the midline correction. The midline correction is very difficult. In general, the midline correction depends a lot of the diagnosis of the patient. In my opinion, when the upper midline is correct and the lower midline is incorrect, in a lot of patients, the main problem is an incorrect position of the lower teeth and need to, in cases with using brackets and wires, use class 2 unilateral, and in aligners use class 2 elastics. But the idea is very simple. In aligners is for alignment. Okay. The idea is not very easy to treat class 2 and unilateral class 2 patient with aligners, because the relationship between the upper and the lower is a little bit different. For the reason I don't have time to talk about the anterior, the proprioception guys. This is the idea. The idea is to use the aligners to engage in class 1 at the end of the mixed dentition, because in the adult patient to treat class 2 or to treat class 2 and unilateral class 2 with aligners is very difficult, in my experience.
Thank you very much, Dr. David Suarez, for this valuable lecture. We would like to have you again in the near future. Whenever you are available and free, just let us know. We have more topics that we will be more than glad for you to share with us. Okay. My dear colleagues, thank you very much for attending today, and we hope to see you soon. Thank you all for attending today. Have a nice evening.
Thank you very much. Thank you very much to all.
Thank you, Dr. Suarez. Thank you so much.
Thank you very much. Okay.
Stay safe. Goodbye.
Thank you. Bye-bye. Stay safe.
Bye-bye.